Auzubillahiminash-shaytanir-rajim. Bismillahir-rahmanir-rahim. Assalamu alaikum everyone and welcome to my channel. This is Asif Qureshi and you are watching Dr Asif Lectures. आज की वीडियो में हम बात करेंगे एड्रिनल ग्लैंड्स के बारे में. ये है हमारे कोर्स की इस लेक्चर की आउटलाइन. We will discuss some basic anatomy about the adrenal glands, physiological circuits, biochemistry, and then we will jump on to the adrenal disorders, which are very important. हम डिस्कस करेंगे कि how to diagnose, how does the patient presents to you, and how do you manage the patient. Okay, so that's going to be a very interesting lecture. Next 50 to 60 minutes, focus on the lecture, and you should have all you need to know about adrenal glands. Okay, so let's begin up with the lecture. Now, the first slide talks about basic anatomy and some important take-home messages. Okay, so you know the location of the adrenal glands is at the top of the kidneys, on each kidney. Therefore, they are also called suprarenal glands. One on the top of the right kidney, the other one on the top of the left kidney, okay? And these glands are supplied by blood vessels. So you need to remember the names of the arteries, that there are superior suprarenal, middle suprarenal, and inferior suprarenal arteries, okay? And each one of the arteries arise from a particular artery. For example, the superior suprarenal artery comes from the inferior phrenic supply. The middle suprarenal artery directly usually comes from aorta, and the inferior suprarenal comes from the renal arteries. The venous drainage from the right suprarenal is to the inferior vena cava, and from the left suprarenal is to the renal vein. The lymphatics from the adrenal glands, they drain into the lateral aortic nodes, and the nerve supply is via preganglionic sympathetic fiber. So that's the basic anatomical stuff that you need to remember. Sometimes in the exams they ask about these things, that what are the branches of different arterial supply to the adrenal gland. So you need to remember and fix that in your head, okay? Let's move on to the structure, which is clinically important for you. You see this triangular structure up there, and the outermost layer is called the fascia, which is part of the renal capsule. And this is important to know here that adrenal glands, they are present in a different compartment of the fascia. Therefore, this is easy for the operating surgeon to mobilize and remove the adrenal gland. So it is not kind of attached with the kidney. They have their own compartment in the fascia. Therefore, their mobility is easy during the operation. Now, the outermost layer, when we do the section of the adrenal gland, it is divided into the outer cortex and the inner medulla. The cortex is derived from posterior abdominal wall. Okay, ये बात आपको याद रखनी है एम्ब्रियोलॉजी के पॉइंट ऑफ व्यू से कि जो कॉर्टेक्स है, this is derived from ये अक्सर सिंगल स्टेज क्वेश्चन पूछा भी जाता है कि from where is the cortex derived from. So you need to remember this is derived from the coelomic epithelium of the posterior abdominal wall. Okay, and the medulla, on the other hand, which is the innermost part of the adrenal gland, is derived from the neural crest cells. Okay. Now, cortex, this is important, guys. Cortex is divided into three layers, and these layers are called zona glomerulosa, zona fasciculata, and zona reticularis. So you need to remember these three names: zona glomerulosa, fasciculata, and reticularis. Now, each one of these compartments release a particular hormone, and you must remember कि कौन से compartment से कौन सा hormone release होता है. Okay? न सिर्फ ये आपको याद रखना है कि कौन से कंपार्टमेंट से कौन सा हार्मोन रिलीज होता है, बल्कि यू शुड आल्सो रिमेंबर कि उस हार्मोन को रिलीज करने के लिए प्राइमरी सिग्नल क्या है. सो यू शुड नो व्हाट इज द प्राइमरी सिग्नल, व्हाट इज द प्राइमरी हार्मोन released by each one of these compartments. Okay, so we'll go through a table here to summarize this. So first of all, आपको याद रखना है ये कि zona glomerulosa, fasciculata, and reticularis, they are all part of the cortex. Okay, so मोटी जो हमने बात की है, the bigger picture is कि adrenal gland is divided into cortex and medulla. Cortex के फिर तीन divisions हैं, glomerulosa, fasciculata, and reticularis. Now zona glomerulosa, जो कि सबसे outer layer है cortex की, this you need to know कि इसका primary regulator कौन है. So what is the main signal for the release of the hormone? Okay, so the main signal here is angiotensin 2. This is important. This is a chemical that you need to remember. Angiotensin 2 comes up to the zona glomerulosa, और इसके orders पर zona glomerulosa अपना काम continue करता है. Okay, और वो काम क्या है? To produce which hormone? The hormone which is produced from zona glomerulosa is called aldosterone. ये एक बिगर ग्रुप ऑफ क्लास है जिसको हम कहते हैं मिनरेलोकॉर्टिकॉइड्स, बट स्पेसिफिक एग्जांपल आपने याद रखनी है एल्डोस्टेरॉन. So remember guys, zona glomerulosa is under the control of angiotensin 2, which is the primary regulator, and it releases aldosterone. Okay, it releases aldosterone. And the group of hormone class जिसे हम कह सकते हैं, the hormone class is mineralocorticoid. So after this we have zona fasciculata, and zona fasciculata is the second layer of the cortex. It releases a group of hormone which is called glucocorticoids. एंड ग्लूकोकॉर्टिकॉइड्स में जो मेन इसका रिलीजिंग हार्मोन है दैट इज नोन एज कॉर्टिसोल. ओके, और कॉर्टिसोल इज सिक्रेटेड अंडर द एक्शन ऑफ ACTH. Now ACTH is another hormone that we will discuss about later. It is released from the upper control centers जिसकी हम बात करेंगे अभी थोड़ी देर में. It is called adrenocorticotropic hormone. Okay, so adrenocorticotropic hormone is the main control of zona fasciculata. So, आप देख रहे हैं किस तरह हम डाइव इन करते जा रहे हैं. पहले हमने बात की कि एड्रिनल ग्लैंड्स आर कंपोज्ड ऑफ कॉर्टेक्स एंड मेडुला, एंड द कॉर्टेक्स इज डिवाइडेड इनटू 3 लेयर्स, जोना ग्लोमेरुलोसा, फैसिकुलेटा एंड रेटिकुलरिस. फिर अब आपने हर एक के बारे में ये याद रखना है कि कौन सा हार्मोन रिलीज होता है किस जोन से, और उस हार्मोन को रिलीज करने का प्राइमरी सिग्नल क्या है. ओके, नेक्स्ट is the zona reticularis, which is the innermost part of the cortex, and it releases a hormone which is called DHEA, dehydroepiandrosterone. Okay, this is also called androgen. The bigger group of the hormone is called androgen, and this is also under the release of ACTH. So here is the summary: cortex and medulla. Cortex is divided into 3 layers: zona glomerulosa, fasciculata and reticularis. Okay, for each one of them you have to remember what is the primary hormone produced, what is the primary control mechanism. Okay, this is very important for you to remember. Now if we talk about medulla, medulla releases epinephrine and norepinephrine, okay, which are combinedly called catecholamines. The bigger group of hormone class is known as catecholamines, and they are under the control of presympathetic nerve fibers. So this is important. Medulla of the adrenal gland is under the control of the presympathetic fibers which are coming from thoracolumbar outflow. You remember that? So from the thoracolumbar spinal outflow, fibers come all the way to the adrenal medulla, and there they control the release of epinephrine and norepinephrine. Okay, so this is a very important slide because the whole lecture ahead is then composed and is based on this understanding that you should know that adrenal gland is composed of cortex and medulla. The cortex is further divided into 3 layers: zona glomerulosa, fasciculata and reticularis, and which one of releases what. Okay, so let's move on to the next slide. Now जब कभी हम कोई ग्लैंड या कोई भी टॉपिक पढ़ रहे होते हैं मेडिसिन में, सो इट इज वेरी इंपॉर्टेंट टू अंडरस्टैंड कि द बिगर पिक्चर, द फिजियोलॉजिकल कंट्रोल किस तरह से है. फॉर एग्जाम्पल अभी हमने बात की कि कॉर्टेक्स और मेडुला से डिफरेंट हार्मोन्स रिलीज होते हैं, उन हर हार्मोन का अपना अपना एक इंपॉर्टेंट फंक्शन है. सो वी हैव टू डिस्कस दोज फंक्शंस, बट इंपॉर्टेंट बात जो इस वक्त हमें समझनी है वो ये कि हाउ, व्हाट आर द फिजियोलॉजिकल सर्किट्स, ये हार्मोन रिलीज कंट्रोल कैसे होता है. सो गाइज, एंडोक्राइनोलॉजी के बाकी ऑर्गन्स की तरह adrenal gland is also by and large under the control of the hypothalamus and anterior pituitary. Okay, now let's see here on the picture you see hypothalamus written at the top and then the anterior pituitary, and you know that these are connected. Now hypothalamus में एक nucleus होता है, PVN यहाँ लिखा है, उसे कहते हैं paraventricular nucleus. So there are nuclei in the hypothalamus which are called paraventricular nuclei, and they release CRH, which is called corticotrophin releasing hormone. So hypothalamus contains paraventricular nucleus जिसमें से हार्मोन रिलीज होगा which is known as CRH. वो CRH कहाँ जाके एक्शन करेगा? CRH will go to the anterior pituitary, और anterior pituitary में जो सेल्स पर वो उसने एक्शन करना है, दो सेल्स आर कॉल्ड corticotrophs. अच्छा, अब ये भी आपको बिल्कुल क्लियर पिक्चर होनी चाहिए कि हाइपोथैलेमस से जब CRH रिलीज होगा और वो कॉर्टिकोट्रॉफ की सरफेस पर जाएगा तो कॉर्टिकोट्रॉफ पर वो कौन सा मैकेनिज्म है जिसे वो एक्टिवेट करेगा? हैव यू हर्ड ऑफ द सेकंड मैसेंजर सिस्टम? One of the second messenger system is cyclic AMP. So it utilizes the cyclic AMP second messenger system. CRH utilizes the cyclic AMP second messenger system. Now, once the CRH has entered the corticotrophs, yani anterior pituitary mein, now anterior pituitary releases something which is called ACTH. See, this is getting complicated, but I will try to make it simple for you. Hypothalamus say, what is released from the hypothalamus? CRH. CRH कहाँ act करता है ऑन कॉर्टिकोट्रॉफ्स. कॉर्टिकोट्रॉफ्स कहां होते हैं? एंटीरियर पिट्यूटरी. और फिर कॉर्टिकोट्रॉफ्स क्या रिलीज करते हैं? They release ACTH. So it's something like bang on from the hypothalamus. From the hypothalamus comes CRH to the anterior pituitary, and then anterior pituitary releases ACTH. Okay? अब ये ACTH कहाँ जाता है? If you remember from the previous slide, ACTH works on adrenal cortex. ACTH works on adrenal cortex. And those zones वो थे जिनके लिए ACTH was the primary stimulus. And those zones were zona fasciculata and reticularis. Okay, so it will go to zona glomerulosa as well, but zona glomerulosa का primary control mechanism है angiotensin 2. So ACTH zona glomerulosa पे भी काम करता है, fasciculata पे भी काम करता है, reticularis पे भी काम करता है, but primary control ACTH वो कौन से regions हैं? वो regions हैं zona fasciculata and reticularis. Okay, so it will go to zona fasciculata and reticularis, again use the cyclic AMP second messenger system and release what? Cortisol and dehydroepiandrosterone. You getting my point? Previous slide से इसको लिंक कीजिए कि ACTH जोना fasciculata पे जब एक्ट करेगा तो क्या निकलेगा? कॉर्टिसोल. ACTH जोना रेटिकुलरिस पे जब एक्शन करेगा तो क्या प्रोड्यूस होगा? एंड्रोजेंस, यानी dehydroepiandrosterone, DHEA. ओके, सो ये पूरा लूप है कि किस तरह जोना fasciculata और रेटिकुलरिस में से कॉर्टिसोल और DHEA रिलीज होता है. एक और चीज है जो कॉर्टेक्स से रिलीज होती है, and what's that? And that is, before that, I also need to mention that once the cortisol is produced, cortisol has an inhibitory action both at the level of anterior pituitary as well as at the level of hypothalamus, which is what we call the negative feedback. यानी जब काफी cortisol produce हो जाता है तो वो जाके अपनी stimulus को stop करता है कि hey ACTH, now I am made enough, please stop, now I don't need more signals, I've been produced enough. So it goes and stops, inhibits ACTH and CRH. Okay, so that's called the negative loop. Now, what else is also produced in the cortex is the aldosterone. And for aldosterone, this angiotensin 2 is the system. And from where does the angiotensin 2 comes? From the renin pathway. Okay, and from where is the renin release? From the kidney. We'll discuss that when we deal with the renal module. But at the moment, you should understand that angiotensin 2 is released from the renin-angiotensin system. और वो कब एक्टिवेट होता है? उसके लिए स्टिमुलस क्या है? द मेन स्टिमुलस इज रीनल परफ्यूजन डिक्रीज हो जाए, यानी ब्लड प्रेशर लो हो फॉर एग्जांपल, या रीनल आर्टरी स्टेनोसिस हो फॉर एग्जांपल, सोडियम लेवल्स अगर कम हो जाएं, या सिंपैथेटिक एक्टिविटी. सो दीज आर द सिग्नल्स फॉर द रिलीज ऑफ renin. And once renin is released, it gets activated, and the system ultimately leads to the production of angiotensin 2. And angiotensin 2 goes to the adrenal cortex. Which zone? Zona glomerulosa. And from the zona glomerulosa then is released aldosterone, and it goes and performs the tissue actions, which we will discuss. Can get tissue actions kya hai? So if we summarize the whole picture one more time, from where the first releasing thing is being released, that is from the hypothalamus. Or hypothalamus mein kaun se nuclei? Paraventricular nuclei. Okay, and from the hypothalamus, the CRH which is released goes and act on the corticotrophs, and the corticotrophs release ACTH, and ACTH goes and work on the zona fasciculata and reticularis and releases cortisol and DHEA respectively. Okay, and what is the stimulus for the release of CRH? It's written at the top here, is stress or the normal physiological circadian rhythm. Okay, so in both these circumstances, these signals go to hypothalamus, hypothalamus release CRH, CRH goes to corticotrophs, corticotrophs release ACTH, and ACTH goes on to adrenal cortex. Okay, so remember this physiological cycle. And for the secretion of aldosterone, what is the primary control mechanism? Angiotensin 2. From where does it come? From the renin-angiotensin system. And when is this activated? When there is low kidney perfusion, when there is low sodium, and when there is sympathetic activation. So I hope this is now very much clear to you, because this is an extremely important image to remember. Okay. Also remember the negative feedback loop, because this is something which will be discussed quite a lot of times in the upcoming slides. कि जब कभी cortisol का level ज़्यादा होगा, it will inhibit the secretion of ACTH. Okay. Now let's talk about the actions. So 3 zones हैं cortex में और एक फिर है medulla. The 3 zones in the cortex are glomerulosa, fasciculata and reticularis. Okay, glomerulosa से क्या निकलता है? Aldosterone. Fasciculata से क्या निकलता है? Cortisol. रेडिकुलरिस से क्या निकलता है? एंड्रोजेंस। तो हम अब इन सब के एक्शंस पढ़ेंगे कि व्हाट आर द एक्शंस। ओके, लेट्स टॉक अबाउट देम। यू नीड टू अंडरस्टैंड कि एल्डोस्टेरोन क्या कर रहा है बॉडी में, कॉर्टिसोल का क्या रोल है और एंड्रोजेंस क्या करते हैं। ये अंडरस्टैंडिंग इसलिए जरूरी है क्योंकि नॉर्मल फिजियोलॉजी आप समझेंगे तो उसके बाद हम डिस्कस करेंगे पैथोलॉजी के बारे में। ओके, सो एल्डोस्टेरोन गोज एंड एक्ट ऑन दीज सेल टाइप्स व्हिच आर कॉल्ड प्रिंसिपल सेल्स एंड इंटरकैलेटेड सेल्स, and they are usually present on the collecting ducts of the kidney. So aldosterone release होने के बाद it goes and act on kidney. Which particular cells of the kidney? Principal cells and intercalated cells. Now कहाँ से release होता है aldosterone? Aldosterone is released from zona glomerulosa. Okay, and what is the primary signal? The primary signal is angiotensin 2. I'll keep on repeating these things so that we are all together understanding and learning this quite easily. So aldosterone comes and act on the collecting ducts, these two particular cells. And on the principal cells, what it does, it reabsorbs sodium, and along with sodium comes water. So the main function of aldosterone is sodium and water reabsorption into the blood circulatory system. Okay, sodium and water reabsorption. What it also does is it loses potassium. So it reabsorbs sodium but loses potassium in the urine, and along with potassium goes the hydrogen. So that slide now overall summarizes the actions of aldosterone. So let's come on, repeat with me. What are the functions of aldosterone? Aldosterone is designed to reabsorb sodium and water into your circulation and excrete potassium and hydrogen out of your circulation. Okay, you pee out potassium and hydrogen. Since you lose hydrogen, it generates a state of alkalosis in the body because you are losing acidity. You are losing acidity and you are generating alkalotic environment in your body by the action of aldosterone. So if you have to summarize what is the action of aldosterone, here it is summarized. The action of aldosterone is salt and water retention. And what will it do? When you retain salt and water, it will increase the blood pressure, it will increase the volume. You are gaining more and more liquid along with sodium, so your volume goes up and your blood pressure goes up. Okay, so these are the things to remember. Aldosterone. और मैं जब कभी मेडिकल स्टूडेंट्स को पढ़ाता हूँ तो हमेशा उनसे कहता हूँ कि जो लेक्चर दिया जाए या जब आप बुक पढ़ रहे हो, so each and every word should make sense to you. So इस डायग्राम पर each and everything written should make sense to you. If it makes sense to you, that means you have understood it. If it doesn't, then rewind the video, see it again, okay? Unless you understand it. What aldosterone also does, I told you, it loses potassium and hydrogen. And since it loses potassium, it generates a state of hypokalemia in the body and metabolic alkalosis. So this slide now completely summarizes what are the actions of aldosterone. In the previous slides, you learned that aldosterone is released from zona glomerulosa under the action of angiotensin 2. And now you have learned what are the functions, what are the actions of aldosterone. Okay? Now, this is a clinical correlate here that the actions of aldosterone can be blocked by a drug. Come on, pharmacy students, attention, attention. Medical students, attention. Actions of aldosterone can be inhibited by a drug which is called spironolactone, very commonly used drug in the clinics. So what does spironolactone and also another analog eplerenone, what is their function? They block the action of aldosterone. Okay, so they will reverse everything. If they block the action of aldosterone, salt will not be absorbed, sodium will not be absorbed, water will not be absorbed, potassium will not be secreted, hydrogen will not be secreted, so that sort of thing. Okay, this is a clinical correlate that aldosterone actions can be inhibited by spironolactone. Okay, I hope this is all very clear. Now, cortisol actions. Cortisol कहाँ से release हो रहा था? From where was it released? Cortisol was being released from zona fasciculata. Okay, and what was the primary control mechanism? ACTH. ACTH कहाँ से release हो रहा था? From anterior pituitary. Anterior pituitary पे under the control of CRH. CRH कहाँ से release होता है? From hypothalamus. So remember this way, okay? You have to remember the whole cycle. Each and everything should be very clear in your head. What are the actions of cortisol? Cortisol, if you talk about cardiovascular system, it increases the blood pressure, okay? It increases the alpha-1 receptors on the arterioles, and thus it increases the sensitivity. It increases the sensitivity to epinephrine, norepinephrine's, okay? Remember this, catecholamine sensitivity is increased by cortisol. cortisol increases sensitivity to catecholamines, and thus it increases the blood pressure, okay? Cortisol, if we talk about its action on liver, the overall action is diabetogenic. And when we say diabetogenic, it means it increases glycogenolysis and it also increases gluconeogenesis. So more glucose production, basically. If we talk about its action on lipids, it increases lipolysis. So breakdown of lipid cells, okay? Muscles, protein catabolism is increased. Immune cells, cortisol decreases leukotrienes and prostaglandins, okay? And this would also mean that the immune system goes down. It reduces WBC adhesion, so the process of leukocytosis is disturbed. It decreases histamine release. It decreases IL-2 production. Now, if IL-2 production is decreased, this would mean that certain loops of your immune system will not be working properly, and therefore it is important. Patients on, say for example, dormant tuberculosis, they start up taking steroids, and because of steroids, which is cortisol, because of steroids, their interleukin-2 levels go down and their tuberculosis is reactivated. So that's a common clinical scenario, okay? A patient who had diabetes, now had dormant or latent tuberculosis, now starts taking cortisol, steroids, and the tuberculosis is reactivated. Why? Because interleukin-2 levels will go down, okay? It also decreases lymphocytes. So overall effect of cortisol on immune system is to decrease the immunity, okay? Remember that. On osteoblasts, it decreases the osteoblast activity, therefore the bones undergo the process of, say for example, osteoporosis, they become weak, okay? And they decreases collagen synthesis, and this is what leads to stria formation, you know. Collagen is not properly formed, and if collagen is not properly formed, the abdominal wall, it shows stria. Why? Because cortisol is in excess. If it is in excess, for example, in Cushing syndrome, so it will lead to decreased collagen synthesis, okay? So this slide then overall summarizes the actions of cortisol. Now let us discuss a very important slide here which describes the formation of these hormones, okay? आपको याद है कि हमने कौन-कौन से hormones discuss किए थे जो adrenal gland से release हो रहे थे? Those were the hormones which were called aldosterone, cortisol, and androgens, DHEA. And from the medulla, what was being released? Catecholamines, epinephrines and norepinephrines, okay? Now, all these are obviously the aldosterone, the cortisol, and the androgens. They are called steroid hormones. And the synthesis of steroid hormones begins from a molecule called cholesterol. And the bracket is the star protein, which is important for, you know, taking up cholesterol to enter into the cycle, and that is the rate limiting step. Now what happens basically is cholesterol is converted by the action of desmolase into pregnenolone, which is then acted upon by 3-beta hydroxysteroid dehydrogenase and produces progesterone, which is 21 hydroxylated and produces 11-deoxycortisone, which is then 11-beta hydroxylated, which produces corticosterone, and finally by the action of aldosterone synthase, aldosterone is produced. Now, all this is happening in adrenal cortex. और adrenal cortex से कौन से zone में? Zona glomerulosa. ये मुझे कैसे पता लगा? Because we are talking about aldosterone production, and aldosterone is produced in zona glomerulosa. Now, you need something to understand कि cortex में ये जो 3 zones हैं, इनमें different enzyme machineries हैं. इसीलिए वहाँ different hormones produce हो रहे हैं. Okay? At the moment, we are talking about zona glomerulosa. Zona glomerulosa का main control mechanism क्या था? What was the main control mechanism? Come on. Angiotensin 2. Okay? But I also told you कि ACTH भी इन पर काम करता है. Zona glomerulosa के जो cells हैं, उस पर ACTH भी काम करता है. But primary control mechanism ACTH नहीं है. Primary control mechanism is angiotensin 2. Okay? There you go. Angiotensin 2 is the primary control mechanism for aldosterone production, and ACTH also works on it. So all this is happening in one zone of adrenal cortex, and that one zone is zona glomerulosa. Okay? Good. Well done. Now, if the pathway doesn't go this way, it can also go this way. The pregnenolone and progesterone can be converted into 17-hydroxypregnenolone and 17-hydroxyprogesterone by action of these enzymes. And it goes down by 21-hydroxylation, produces 11-deoxycortisol. By 11-beta-hydroxylation produces cortisol, which can also be converted into cortisol, you know. Now, if this happens, this is happening in cells of zona fasciculata, because it is producing cortisol and it is directly under the control of ACTH. Now, remember this is a little complicated because there are so many names, there are so many enzymes. You don't have to remember all of them, for example, but some of them are very, very important. We will talk about them. वो enzymes और वो hormones हैं जिनको आपको याद रखना है, उसके बगैर you can't pass your boards exams, okay? Because वो exams में बहुत पूछते हैं, चाहे वो आपके undergrad exams हो या postgraduate exams हो. I will tell you which one are high yield. High yield topics you have to remember. Low yield stuff you can live with, okay? It's up to you if you want to spare your brain memory for low yield stuff, up to you. But this is high yield. At least some of the points from there are high yield, okay? Now, this was zona fasciculata. Now, let's talk about zona reticularis, where DHEA, dehydroepiandrosterone, and the other androgen, which is androstenedione, they are produced. Now, to summarize this picture is talking about adrenal cortex, how they produce different hormones, and what are the different enzymes involved. Okay, so if you're talking about this particular area, one shaded in brown, this is the production of aldosterone in zona glomerulosa. If it goes this way, this is the production of cortisol, which is zona fasciculata. And if it goes this way, this is the formation of androgens. Okay, now let us talk about some important enzyme deficiencies, which are very, very high yield, and they are asked in the exam quite a lot. Okay, so let's talk about them. So there is a condition which is called 17-alpha hydroxylase deficiency. It's an autosomal recessive disorder, and you need to understand if 17-alpha hydroxylase is not working, what will happen? Let's discuss. So look at the image here. वो कौन से points हैं where we see 17-alpha hydroxylation? These are the points crossed in red. So if those areas are blocked, what will happen? You know, जब आप रोड पे चल रहे होते हैं, when you are going to a road, और हमारे यहाँ तो ये बहुत commonly होता है कि आप एक रोड पे जा रहे हैं, अचानक सामने बैरियर लगा हुआ है कि जी यहाँ से नहीं जा सकते for XYZ reason, ये रास्ता बंद है. What will you do? You will obviously take a bypass. आप किसी और गली में किसी और रोड की तरफ मुड़ जाएंगे. तो होता ये है कि अगर मेन रोड्स क्लोज हो जाएं, तो जो कोलैटरल्स हैं वहाँ ट्रैफिक बढ़ जाता है क्योंकि सारा ट्रैफिक उस तरफ डाइवर्ट होता है. बिल्कुल इसी तरह यहाँ भी है. अगर 17 हाइड्रोक्सिलेशन स्टॉप हो जाएगी तो वो रोड तो हो गया बंद. अब सारा ट्रैफिक जाएगा इस तरफ, और जब ट्रैफिक इस तरफ जाएगा तो क्या ज्यादा बनेगा? एल्डोस्टेरॉन. और क्या कम बनेगा? कॉर्टिसोल और एंड्रोजेंस. सो अगर 17 अल्फा हाइड्रोक्सिलेज डेफिशिएंसी होगी, if there is 17 alpha hydroxylase deficiency, what will be high? Aldosterone. What will be low? Cortisol and androgens. Okay? अब आपको यहाँ ये पता होना चाहिए कि जब एल्डोस्टेरॉन हाई होगा तो एल्डोस्टेरॉन के एक्शंस क्या क्या होते हैं? एल्डोस्टेरॉन के एक्शंस होते हैं इंक्रीज सोडियम एब्जॉर्प्शन, increase water absorption, increase blood pressure. Bang on. This is important point. 17 hydroxylase deficiency patient will have high blood pressure, increased blood pressure. Okay? Why? Because aldosterone is working more. So patient will have high blood pressure. Okay? What will be the status of patient's potassium? Hypokalemia. Very good. Hypokalemia. What will be the status of in terms of acidity and alkalosis, metabolic alkalosis? Why? Because increased aldosterone, more potassium out of the body, more hydrogen out of the body. You got my point? So remember this, whenever there is hyperaldosteronism, which here is the case, there is 17 hydroxylase deficiency. So as a result, aldosterone is produced more. So there will be blood pressure, there will be hypokalemia, there will be metabolic alkalosis. Okay, all these points you should remember. And cortisol and androgens will be reduced. Now, let's talk about another deficiency, which is now 21 hydroxylase deficiency. So where is the 21 hydroxylation step? These two. If these are blocked, these roads down there will be blocked and the traffic will be diverted towards androgens. So more androgens, more androgens. Now, more androgens means the patients, if it's a female patient, it will present with viralization of female genitalia, male-like secondary sexual characteristics, hirsutism, okay? So these kind of things. Blood pressure will not be increased because aldosterone is not increased. So there will be no disturbances as far as the potassium levels are concerned. So remember these things. These should all make sense. Why in 17 hydroxylation there is increased blood pressure? Because there is more aldosterone. And 21 hydroxylation, aldosterone is not produced. So all this should make sense to you. Now you understand why I said this is clinically very important. This is high yield. You have to understand the consequences of 17 hydroxylase deficiency. You have to understand the consequences of 21 hydroxylase deficiency. It should make sense to you. Now I know there are so many mnemonics out there in the market. Say for example, one of the leading books, they talk about कि अगर 1 से शुरू होगा तो blood pressure होगा, 1 pant होगा तो yoga. So how would you remember that all? You know, that's short-term memory. Mnemonics is short term memory, क्योंकि इतने ज्यादा mnemonics हैं कि आपको mnemonics याद रखने पड़ेंगे. How will you do that? So try to understand the concepts. I'm a concept person, you know. Try to understand the concept. 17 hydroxylase deficiency होगी तो aldosterone ज्यादा बनेगा. अब aldosterone के जितने भी functions हैं वो सब ज्यादा हो जाएंगे. As simple as that. So remember what is aldosterone doing, okay? So make concepts. Now when 21 hydroxylase deficiency is there, you know it's blocked at these levels. Cortisol will be low, aldosterone will be low, androgens will be high, okay? Now if we talk about 11 beta hydroxylase deficiency, these are the steps where 11 beta hydroxylase is working, and once these are down, cortisol and aldosterone production will be low, androgens will be high. But one difference from the previous one, one difference from 21 hydroxylase. 21 hydroxylase was here, and it was here, and 11 hydroxylase is here, which means just above 11 hydroxylase in the aldosterone pathway is 11 deoxycorticosterone. Okay, now this thing has a mimetic activity like aldosterone, so it raises the blood pressure. Now this is important. A patient with 17 hydroxylase deficiency has high blood pressure, but a patient with 11 beta hydroxylase deficiency also has a high blood pressure, but for a different reason. The reason in the 17 hydroxylase deficiency was increased production of aldosterone. Here aldosterone is not being produced, but a precursor molecule which has almost similar action is being produced in more amount. So see, it's important to understand the concepts. And now this chart describes everything for you. Okay? Now see, this should make sense to you now because we have already discussed it. Look at the top, 17 hydroxylase deficiency. What will happen to aldosterone? High. Potassium, low. Blood pressure, oh, I can read it for you, but you need to understand it. Each and every word should make sense to you because we just discussed it. Okay? And remember, 17 hydroxylase deficiency and 11 beta hydroxylase deficiency both will have high blood pressure. And particularly interesting is 11 beta hydroxylase because see, what is the level of aldosterone is 11 beta hydroxylase. Aldosterone is low. So just by looking at aldosterone, you may think, oh, aldosterone is low, the blood pressure will be low. But no, I just told you that one of the precursor molecule is increased, which performs similar activity, okay? And it raises the blood pressure. So guys, try to make concepts, okay? Make concepts. Now, the previous diagram, we talked about cortex, hormone synthesis in cortex. Now we are jumping into the medulla. And in the medulla, the cells which produce catecholamines are called the chromaffin cells. And the chromaffin cells are under the control of this pre-sympathetic fiber, okay, which is emerging from the spinal T1 to L2, thoracolumbar sympathetic outflow. These are the preganglionic fibers coming to the chromaffin cells. On the chromaffin cells, they release acetylcholine, and the whole pathway is initiated starting from tyrosine. So tyrosine is initially converted into dopa, and which is then converted into dopamine, and dopamine is converted into norepinephrine, then epinephrine, and the byproducts, these are the metanephrines, and then mandelic acids. Okay, you obviously can remember the whole pathway if you want, and I don't actually recommend rectifying everything, trying to understand, okay? So catecholamines are the main products from chromaffin cells, but it also releases the byproducts, okay? It also releases the metabolites, and the metabolites are VMEA and DH dihydroxy, mandelic acid, and metanephrines, which are metnoradrenaline and metadrenaline, okay? Present down there. Now that we have discussed the basic anatomy, physiology, biochemistry, and some basic important stuff about adrenal glands, now is the time to discuss the adrenal disorders. This would have not been possible without understanding कि किस तरह hormones बनते हैं, कहाँ hormones बनते हैं, कौन से hormones बनते हैं, and then what are the functions of those hormones, okay? Once you have cracked the basic stuff, now we are ready to deal with the patients, okay? Now, one more very, very quick review. Adrenal gland is divided into cortex and medulla. Cortex is divided into three layers: zona glomerulosa, fasciculata, and radicularis. Each one of them releases a hormone. Zona glomerulosa releases aldosterone under the action of angiotensin II. Zona fasciculata releases cortisol under the action of ACTH, and zona reticularis produces androgens also under the action of ACTH. But these androgens are very weak androgens, have a minor role, particularly in females, in the development of secondary sexual characteristics and libido, the sex drive. You know the function of aldosterone: increased salt and water reabsorption, more potassium and hydrogen release. So it causes increased blood pressure, hypokalemia, and metabolic alkalosis. You know the action of cortisol: decreases immune system, lipolysis, diabetogenic, increased cardiovascular actions, okay? Heart rate and blood pressure. So you know that basic stuff now. Now we are moving towards adrenal disorders. Now, what sort of disorders we will be discussing? They include hyperaldosteronism, when aldosterone is produced more. There is hypercortisolism, when cortisol is produced more. And both these are cortex. Also, not only they are produced more, in some diseases, they are produced less. So the easy way to remember this: there are conditions where these hormones are produced more. There are conditions where these hormones are produced less. And once they are produced more, all their actions will be more. When they are produced less, all their actions will be less. So easy to remember, isn't it? So we try to make medicine easy for our students, okay? And then there is a medulla condition which we need to discuss, is pheochromocytoma, okay? So the summary of the disorders will be hyper conditions, hypo conditions in the cortex, and then in medulla, pheochromocytoma. So let's begin with hyperaldosteronism. जब कभी कोई disease आपके सामने आती है, so you need to ask yourself कि disease है क्या? For example, अभी मैंने यहाँ एक word लिखा है hyperaldosteronism. So you should ask yourself, what is hyperaldosteronism? By definition, it is increased production of mineralocorticoids, increased production of aldosterone, okay, from the adrenal gland. This is hyperaldosteronism. Now, when there is hyperaldosteronism, by default, it should click in your head that there is more water and sodium retention, there is more potassium and hydrogen loss. Does that make sense to you? Yeah? Important, it also causes metabolic alkalosis. You know that already. And another point is 5 to 10% of all hypertensive cases are because of this problem. Oh, important. In your clinics, you see a lot of hypertensive patients. You will see a lot of hypertensive patients. Many of them, 5 to 10% is a lot, is because of this problem, hyperaldosteronism, okay? So if you diagnose it correctly, you should be able to then address the issue. क्योंकि अगर किसी को, if somebody has hyperaldosteronism और आप सिर्फ blood pressure की दवाइयां देते जा रहे हैं without addressing the original issue, you are not helping the patient, okay? The patient will be in trouble. Now, you should suspect hyperaldosteronism in any person who is coming to you with, sustained hypertension, sustained blood pressure, which is non-responsive to routine hypertensive therapy, and the person is young. This should ring bells in your head. A young patient coming to you with uncontrolled hypertension, fails to respond to any of the hypertensives, that's your case of investigating hyperaldosteronism, okay? And there are usually sweatness and weakness, these are symptoms, but whoever comes to you with blood pressure and hypokalemia, blood pressure which is not being controlled by antihypertensives, and the patient also has hypokalemia, it's a spot-on diagnosis, hyperaldosteronism, okay? You should investigate the patient. See, I want to make life easy for you. Hyperaldosteronism, what is it? Increased aldosterone. How does the patient present to you? Uncontrolled blood pressure and hypokalemia. Investigate the patient, okay? It can be primary, it can be secondary, it can be non-aldosterone dependent. So in pathology, we say anything which is primary means that the original issue is within the gland. If there is increased aldosterone production because there is something wrong within the adrenal gland, this is called primary hyperaldosteronism. See here what's written? Primary hyperaldosteronism is bilateral adrenal hyperplasia or adrenal adenoma. So if in the adrenal gland, in the zona glomerulosa, it's hypertrophied, it's hyperplastic, it has a lot of cells, and it is producing a lot of aldosterone, that's the primary hyperaldosteronism. And sometimes what happens in the adrenal gland, in the zona glomerulosa, there is an adenoma which produces a lot of aldosterone. So this is also an example. Either it is generalized hyperplasia or hypertrophy, or it is a focal adenoma, it produces a lot of aldosterone, that's primary hyperaldosteronism. And what will happen? What will be the levels of aldosterone? Oh my God, that's a difficult question, isn't it? This is hyperaldosteronism. Oh, it will be high. Aldosterone levels will be high because it is hyperaldosteronism. High aldosterone levels, okay? And if the aldosterone levels are high, what will be renin? Down, negative feedback. If aldosterone is high, it will inhibit renin, negative feedback. Simple. If cortisol is high, inhibit the ACTH. If aldosterone is high, inhibit the renin. So this should make sense to you. Everything written here should make sense to you, okay? And then there is another condition which is called secondary hyperaldosteronism. And secondary hyperaldosteronism is increased production of aldosterone, not because the adrenal is itself producing a lot. It's because of some other cause. And when we say some other cause, see here, for example, there is inadequate renal perfusion. There is renal artery stenosis. Diuretics are being used, cardiac failure, liver. In all these conditions, what will happen? Blood supply to kidney will be reduced. Now, when blood supply to kidney is reduced, kidney produces a lot of renin. And that renin produces angiotensin 2 ultimately, which goes into the adrenal glands and produces a lot of aldosterone. So the production of aldosterone in this particular example is not because there is something wrong within the gland, but it's because of some other cause. The other cause is hypovolemia, renal artery stenosis, cardiac failure, liver failure. All these conditions increase production of renin. So in this case, increased production of renin and increased production of aldo. Okay, aldosterone wants to inhibit renin. Come on, I'm a lot, you go away. But renin says, no, I will not go away because I have low blood pressure to deal with. That's enough of a signal for me. So see there? Now you understand? In secondary hyperaldosteronism, there is increased renin and increased aldo. Why? You know this, okay? And then there is a condition which is called non-aldosterone dependent. That's not usually asked on examinations, but they may do. That's because of the Little syndrome or liquorice. We'll talk about this later in upcoming videos. But primarily, you need to understand what is primary hyperaldosteronism, when there is something wrong within the adrenal gland, adenoma, which is also called Conn syndrome, and hyperplasia of the adrenal gland. And secondary is when there is something wrong in the renal circulation system, and because of that, there is more renin, and more renin leads to more production of angiotensin 2, which then leads to more production of aldosterone. Okay? Now, talk about the labs. What is the best test? Oh my God, this is, in exams, they love this. They love this. They want to ask, they want to give you a picture, and we will discuss this in the next video with all those who have registered in the course. Okay, this is the presentation of the patient. What would you do next? Okay, so important laboratories that need to do is we do plasma aldosterone levels, which is obviously high in cases of hyperaldosteronism. But the more sensitive test than plasma aldo levels is the aldo-renin ratio. So here it is. You remember this slide? If aldo is high and renin is low, primary hyperaldosteronism. If aldo is high, renin is high, secondary. Okay, so plasma, renin and aldosterone levels, the ratios, they're very important. And obviously you will have hypokalemia. You know why? Because there is more aldosterone. You will have urinary loss of potassium, and you should think about CT and MRI. Now here is an important thing. People also do postural aldosterone level, lying down and then in supine in different positions. People also consider venous catheterization, of the circulation that is coming out of the adrenal to actually accurately measure the levels of aldosterone. But that's very deep and invasive procedure, although it is more accurate than any of the above listed. But this is not routinely done. Okay, the routine thing which gives you the diagnosis is aldosterone-renin ratio. So from the aldosterone-renin ratio, you'll be able to tell if it is primary or if it is secondary. So if you suspect a primary hyperaldosteronism, then you plan CT scan or MRI to see if it's an adenoma. If it is the adenoma, what is the location, what is the size, what is the penetration, what is the depth. Guys, here is a rule of thumb for you. Almost all of the time it works. In endocrinology patients, never do a scan before you have the laboratory tests available. Remember this. Otherwise, what we'll do is, you'll do the CT scan, you'll do the MRI, and you find a lot of incidental findings. You may end up, in removing the wrong organ. You don't want to remove the wrong organ. Hey, I did the CT scan. On the CT scan, there is a gold lump there, Remove the lump. No, you don't want to do that, You need to confirm if the lump is a problem for you. And how you do that is by biochemistry laboratory tests, okay? So labs, biochemistry first in endocrinology problems. Always do biochemistry first and then plan a scan. In examination, CT scan therefore is usually not the next best step in the management if you do not have the labs, okay? So do the labs first and then plan a CT. That's the rule, okay? So in hyperaldosteronism, establish if it is hyperaldosteronism, you can do the plasma aldosterone levels. You then need to establish if it is primary or secondary. In that scenario, you need to do the ratio, aldosterone-renin ratio. And once you identify this is a problem with aldosterone production and it is because of primary, plan a CT scan. Plan a CT scan. Hypokalemia and urinary loss of potassium, they are associated findings, you know that. And these are not something on which you will base your diagnosis. In order to establish hyperaldosteronism, you need to do aldosterone levels, or better to do aldosterone and renin ratio, okay, followed by a CT scan. Now, how do you manage the patient? If it is an adenoma, do a surgery, remove the adenoma, that's the plan. If it is a hyperplasia, you cannot remove the whole gland, you know, hyperplasia is much more generalized. In that case, you use aldosterone antagonist because the problem here is increased production of aldosterone. Stop it. If you can't remove it, stop it. And I told you it can be done by spironolactone and allopurinol, okay? Also to control blood pressure, we can use calcium channel blockers, okay? But those are only controlling the blood pressure. The primary cause should be treated. If it's an adenoma, do the surgery. If it's hyperplasia, block aldo, okay? Now let us discuss hypercortisolism. Now I told you that there are hyper conditions and then hypo condition. Hyper condition of hyperaldosteronism, we discussed that just now. Now we'll talk about hypercortisolism. When we say hypercortisolism, it by definition means increased cortisol levels. It's also called Cushing syndrome, okay? Now, increased cortisol levels, and what can be different causes for this? Different causes could be, let's begin from the very top. There is a condition in which there is ACTH secreting pituitary adenoma. So now think about it, oh my God. If this was the first thing in the lecture that I would have told you, ACTH secreting adenoma, what the hell is this? Now you know. Now you know because I've told you where is ACTH released from? Come on, anterior pituitary. So if in the anterior pituitary there is an adenoma which secretes ACTH, a lot of ACTH, a lot of ACTH, a lot of ACTH, where does it go? Adrenal cortex. Which zones? All zones, but primarily fasciculata and radicularis. What is produced from fasciculata? Cortisol. So increased ACTH, increased cortisol. Increased ACTH, this particular axis is called Cushing disease. Now then there can be another condition which is ectopic release of ACTH. Patients with squamous cell carcinoma, for example, in the lung, they release a lot of ACTH. So that ACTH also governs your adrenal gland and produces a lot of cortisol. Now, there can be adrenal adenoma, hyperplasia, cancer, whatever, problem within the gland. Problem within the gland. So if there is a problem within the gland, it will produce a lot of cortisol. But in this case, ACTH will be low. Oh my God, I love biochemistry. I love biochemistry. I love laboratory findings. You see here? In the first two conditions, Cushing disease and ectopic, what will be the levels of ACTH? High. Because that's the primary pathology. High ACTH level, high cortisol. But in this particular case, if there is adrenal neoplasia, if there is adrenal adenoma, if there is adrenal hyperplasia, cortisol will be high, but what will happen to the levels of ACTH? It will go down because remember, more cortisol, negative feedback, less ACTH. Beautiful, isn't it? You start making sense out of it? Yeah? I like it. I like it, by the way. Now, there can also be high cortisol levels because of exogenous steroids. In this case also, ACTH will be down because there is a lot of cortisol already there. It will inhibit, it will have a negative loop back, you know, on the ACTH production. Now, remember, this is key to the understanding of diagnostic algorithm that we will discuss in the later upcoming few minutes. This is the basis. You need to understand that in Cushing disease and in ectopic ACTH release, levels of ACTH are high. But in conditions where adrenal gland is affected or you are taking exogenous steroid, cortisol will be high, but ACTH will be low. And because ACTH is low, the remaining part of the adrenal gland will undergo atrophy. You think, come on, be with me on this. This is an adrenal cortex, and there is an adenoma. This adenoma is releasing a lot of cortisol, okay? Now that cortisol inhibits ACTH. Now because ACTH is inhibited, anything in the adrenal cortex next to this adenoma is not getting any signal from ACTH. So the remaining gland will undergo atrophy, okay? So there will be a hyperplastic region, adenoma, and then the rest of the gland will be atrophied, okay? Right. Now, how does the patient with Cushing present to you? These are all the findings, and there is also usually a picture which is shown, a buffalo hump person, moon-faced, abdominal, truncal obesity, stria. So all these are listed down here. On the skin, there are easy bruises in stria because collagen synthesis is disturbed. I told you. There is fat redistribution because there's a lot of lipolysis, so moon-faced and buffalo hump, all those things. Osteoporosis because there is decreased osteoblastic activity, and the immune system is down. There is erectile dysfunction and also menstrual disturbances. Okay, so remember this presentation. One very important slide. In examination, I bet you will get one of the question out of this. Whether it is a USMLE examination or it is an MRCP examination or it is a PLAB examination, you'll get something out of it. This one picture, okay? See, patient coming to you, it's a weak patient coming to you, tired. Oh my God, I'm not fine. There's a lot of hair growth on my face and strange marks on my abdomen. Stria. What would you do next, okay? The next thing, so you are already with the physical appearance and these findings, you have in your mind that this patient may have Cushing syndrome, okay? What will be the next step? This is what you will do. You do the late night salivary cortisol levels, okay? And you check dexamethasone suppression. And what does that mean? In the night, you gave a little dose of dexamethasone, a little dose, 1 milligram, and you see in the morning what are the levels of cortisol, if the levels are inhibited or not, okay? And you can also do 24-hour urinary cortisol. So basically, we are trying to establish in this patient if the cortisol levels are really high or not. So that's the first thing to establish in a patient with Cushing disease. Whenever you suspect a patient with Cushing, the first thing you need to establish is if the levels of cortisol are high, they are really high or not. So in order to see if the levels are really high, these are the things you can do. You can do a late night salivary cortisol level test. They may come up high. You can do a cortisol suppression test. If the levels are high, it will not be suppressed. So in the night, you give the patient dexamethasone. It should suppress the normal physiological cycle, but if it doesn't, it means there is something wrong and the cortisol levels are high. And if you measure 24-hour urinary cortisol, which is very, very sensitive test, then you also come to the conclusion that cortisol levels are high, okay? So first thing to establish is the cortisol levels, and then you need to establish what is the source, from where is this cortisol being released, okay? So we'll talk about it. Now, do a measurement of serum ACTH. If the serum ACTH level is low, think. If the serum ACTH levels are low, it's not pituitary adenoma, it's not ectopic stuff. Yeah, you getting my point? If the ACTH levels are low, what would you do next? If the ACTH levels are low, it's either something wrong within the adrenal gland or it is exogenous steroid. We discussed this. We discussed this in the previous slide. You see here I told you. Here I told you. I told you there. So if ACTH levels are low, it is either something wrong within the adrenal glands or somebody is taking exogenous steroids, okay? And this is what the algorithm tells you. Patient comes to you, you suspect Cushing's, you do any of these things to establish high cortisol levels and then measure serum ACTH. If serum ACTH is low, then it is either exogenous steroids or adrenal. Now you do the CT scan. Now you do the CT scan to see where is the adenoma or if it's a carcinoma. Now you do the scan. Locate where is the problem. Scan is not the first thing in endocrinology. In endocrinology, you need to establish the cause first by laboratory biochemical profile, okay? So biochemical profiles, biochemistry is the first thing to do. Establish the biochemistry, then do the scan. Now, if the ACTH level comes up to be very high, then this is something which is ACTH dependent. Okay, and ACTH dependent, next thing would be high dose dexamethasone suppression test. Now, previously in the overnight dexa suppression, you gave short dose, small dose, but now you are using a high dose suppression. If there is no suppression, even by using a high dose, if there is no suppression, then it would usually mean that there is some ectopic source of ACTH. Okay, now you should plan CT scan of chest, abdomen, and pelvis, because anywhere there can be a source, a cancer, for example, which is releasing a lot of CT scan. But if there is suppression would mean that there are chances that there is a pituitary adenoma, because pituitary adenoma would usually be suppressed if you use high dose dexamethasone. So getting my point, patient comes to you with suspected Cushing syndrome, you establish that there is high cortisol level. The next best step in the management would be to measure ACTH levels. If ACTH levels are low, this is either exogenous problem or problem within the adrenal. Do the CT scan. If ACTH levels are high, the next thing you do is the high dose DEXA suppression test. If it is suppressed, the problem is within the pituitary. Do a CT scan. If it is not suppressed, the problem is ectopic. Okay? Another test we do, the stimulation, is the CRH stimulation. Remember, where is CRH released from? Hypothalamus. Where does it act? Anterior pituitary. Okay? So you do the CRH stimulation. And if there is an increase in ACTH, an increase in cortisol, the problem is in the anterior pituitary. Okay? But if ACTH and cortisol levels are not affected by CRH, it's not the central axis, it is ectopic. Okay? So remember, this algorithm is very important for you to fix the problem. You fix where is the source, you fix where is the problem, and only then you can treat. Okay? Now let's talk about the management. If surgery is possible, and you're talking about once you have located where the tumor is and you are very sure that you can do the operation, if the surgery is possible, do the surgery. It's usually transsphenoidal if it's for the pituitary. Okay? If the problem lies within the pituitary, you do the transsphenoidal surgery. If it is adrenal source, usually laparoscopy is done, and this is the target cortisol that you should target, 150 to 300 nanomoles per liter during the day. If this is achieved, your management is successful. Okay? And if surgery is not possible, for example, you try to inhibit cortisol. Okay? One of the drugs, for example, listed here, mifepristone, it blocks the cortisol receptors throughout the body. Mitotane is another drug that is commonly used, which blocks steroid synthesis. Right? Now, this is also worth mentioning, Nelson syndrome. Now, Nelson syndrome usually happens after bilateral adrenalectomy for Cushing disease. Now, this is rare nowadays because nowadays Cushing disease is not usually treated by bilateral adrenalectomy. So we don't remove adrenal glands nowadays just to treat Cushing disease. There are modern advanced form of management forms available. Therefore, we don't do this. But anyways, you need to understand that this is a syndrome which has traditionally been asked in the exam, that what is Nelson syndrome? It usually happens after the release of adrenals, okay, basically. And it is presented usually with hyperpigmentation because there is a lot of ACTH, and ACTH does not have the target to work on. Adrenals have been removed. So that ACTH, along with this, is melanocorticotropin hormone, which is released, which causes high pigmentation, okay? So that can cause a problem. Anyways, and the treatment and the way to deal this would be to do a radiotherapy of pituitary, so that pituitary is also suppressed if the adrenals are removed, okay? But as I said, these are rare nowadays because this is not a common treatment modality these days. So up till now, we have discussed two conditions in which the adrenal hormones are increased in their quantities. One was hyperaldosteronism and the other one was hypercortisolism, okay? And I told you this is very important to first establish that the hormone levels are increased and then establish the source and locate them, okay? So never do the CT scan first, it's not a good idea. Otherwise, as I said, you will end up removing the wrong organ, all right? So biochemistry first, followed by the scans. Now, after the hyper conditions, we are now going to discuss a condition where there is adrenal insufficiency, the hypo condition, okay? So by the word, we should understand adrenal insufficiency means there is decreased mineralocorticoid, decrease cortisol and decrease androgens, okay? So everything is decreased, and this is therefore called adrenal insufficiency, or to be very correct, it should also be called adrenocortical, because these are all the cortical hormones, adrenocortical deficiency, okay, or insufficiency, also known as Addison's disease. Addison disease is the other name for adrenal insufficiency. What was Cohen's syndrome, by the way? Cohen's syndrome was hyperaldosteronism. What was Cushing's syndrome? Hypercortisolism. Cushing disease, when it is because of pituitary tumor, high ACTH, Cushing disease. Yeah, so remember these things, and we'll take care of them when we discuss the clinical cases, okay? So adrenal insufficiency, everything is reduced, okay? Now it can be primary adrenocortical sufficiency or secondary. Primary, if there is something wrong within the gland, for example, autoimmune disorders. Usually in the in the developed countries, this is the most common cause of adrenal insufficiency, autoimmune disorder. However, in the developing country like ours, tuberculosis is the most common cause, is one of the most common causes of destruction of the adrenal gland. Okay, so in any case, the adrenal gland is destructed, and because of the destruction, the hormones produced by the adrenal gland are also reduced. Okay, so there are other causes such as hemochromatosis or metastasis from some other location, but you need to know these two top common causes. In developed world, it is usually autoimmune disorder. In developing countries like that of ours, this is usually tuberculosis. Okay, and then the secondary cause is somewhere outside the gland. So the gland is okay, but there is, for example, hypothalamic disease. There is a pituitary problem. There is, a withdrawal effect because you are now withdrawing the glucocorticoid therapy. So any problem that is outside the adrenal gland and affecting the production of the adrenal hormones is the secondary, okay? And what happens if this happens? Now you should make sense, If there was more aldosterone, you know what happens. If there is less aldosterone, you should know what happens, okay? Have a look here. If there is low aldosterone levels, there will be so many effects, okay? There will be so many effects. There will be hypertension or hypotension. Hypotension. Hypertension was a feature of hyperaldosteronism, okay? And then hyponatremia, hyperkalemia, metabolic acidosis. So everything reverse direction, okay? And the features of glucocorticoid deficiency are written here: hypoglycemia, hypercalcemia, and androgens. In females, usually it will present as decreased body hair growth, loss of libido, particularly in females, because in males, testosterone, which is produced in the testicles, it takes care of the function of the androgens, okay? But in females, you may see some of the characteristics such as loss of libido or loss of secondary sexual characteristics. So these are the listed effects when these hormones, cortisol, aldosterone, and androgens, they are reduced in number, okay? In all of these cases, if there is a primary problem, you see, adrenal gland is not working, what will be happening to the levels of ACTH? It will be increased. It will be increased in order to, make an attempt to make more and more and more release of these adrenocortical hormones. ACTH levels will be increased. And whenever there is increased ACTH production, there is increased melanocyte, producing factor also increased, and that leads to high pigmentation, increased pigmentation. So increased ACTH, increased pigmentation in the mucous membranes, in conjunctiva, is an indicative that your adrenal gland basically is not working, and the ACTH is produced in more and more amounts. So suspect all these patients. This is very important for your examination purposes. See what is written here. Suspect all the patients with unexplained fatigue, hyponatremia, hypotension, and you are not able to find out what's the cause. Always investigate the adrenal axis. Always investigate if the adrenal glands are working properly, because these patients do present something like which you can easily miss. Imagine a person coming to you with complaints of fatigue, and you have investigated hell lot of things, but you have not investigated adrenal axis. So you will miss this patient. So this can be serious, It's a chronic problem, but at times it is precipitated by some factors such as we will discuss in later on. So if there are some precipitants available, it can be a fatal disease. It has very high mortality in acute conditions. Okay, so you need to diagnose this patient. Anyone coming to you with unexplained fatigue, hyponatremia, hypotension, and you are unable to figure out what's the cause of hypotension and fatigue, please investigate adrenal axis for adrenal insufficiency, okay? So that's the primary, that's all about the primary adrenal insufficiency. There will be increased pigmentation and increased ACTH. But in secondary adrenal insufficiency, obviously there will be no pigmentation because there is no high levels of ACTH. Actually, there may be low levels of ACTH, so pigmentation is not under question, okay? Now, what are the labs that you will do? Usually what you are going to do first is the random plasma cortisol levels, okay? Just check if the cortisol levels are enough or not, and that should give you the idea. Usually it should be more than 500. More than 500 nanomoles per liter. If this is the result, you exclude adrenal insufficiency. That's how it is. So the first thing to do is just check the cortisol levels. If the cortisol levels are more than 500, patient is doing fine. It's not the problem with adrenal glands, okay? And then if it is low, then you do this short synectin test, okay? Short ACTH stimulation test. Now this is important to understand this. This is for the diagnosis of primary or secondary adrenal insufficiency. So here again, one more time. If you are suspecting a person with adrenal insufficiency, the first thing to do is do the plasma cortisol. If cortisol levels are more than 500 nanomoles per liter, you exclude adrenal insufficiency. If cortisol levels are low, then you need to understand and fix if it is primary adrenal insufficiency or secondary adrenal insufficiency. Now, in order to locate primary or secondary areas, you need to do this short synectin test, okay? And how you do this is you do intramuscular injection of 250 micrograms of ACTH, and then you take readings of ACTH at 0 minutes and 30 minutes, okay? And at 0 minutes and 30 minutes. And normally the plasma cortisol levels, not only ACTH, but you also measure cortisol levels, okay? So I beg my pardon, so let's repeat it one more time. So if you are doing the short synectin test, what you do is you inject the person with intramuscular injection of ACTH, 250 micrograms, and then at 0 minutes and 30 minutes, you measure the cortisol levels. You measure the cortisol levels. And if the cortisol levels, they rise above 500 nanomole at either 0 minute or 30 minute. If they rise, it's secondary adrenal insufficiency. Because the adrenal gland, now try to make sense out of it. If the adrenal gland is okay and it is just waiting for ACTH to come and give me the signal and I will produce the cortisol, what is it? Primary problem or secondary? Secondary problem. And in this case, if I use external ACTH and I'm stimulated, and I'm okay, I will start producing a lot of cortisol. So if cortisol level increases either at 0 minute or 30 minute, this is a secondary problem. And if cortisol levels don't rise, there's a primary adrenal insufficiency. So one more time, this is worth spending. This is worth spending because this also is one of the favorite questions of board's exam, either MRCP, USMLE, whatsoever, PLAB examinations. This is one important concept, okay? So if you are suspecting a person with chronic fatigue, hyponatremia, hypotension, and you are a good doctor and you suspect adrenal insufficiency, you order cortisol. The cortisol levels are more than 500 nanomoles per liter. You exclude adrenal insufficiency. But if cortisol levels are low, now you need to fix if it is a primary problem or a secondary problem. And what do you do for that? For this, you order a short synectin test. And in a short synectin test, you inject 250 micrograms of ACTH intramuscularly and take the readings of cortisol at 0 minutes and 30 minutes. If at 0 minutes or 30 minutes cortisol levels are rising, that's a secondary adrenal insufficiency. If cortisol levels don't rise, that's the primary problem, okay? I hope this is now very much clear to all of you. Now, you can also do mineralocorticoid assessment and then androgen assessment, but that's usually not done because if you establish the cortisol levels are low and short synectin test, you establish adrenocortical insufficiency. But for mineralocorticoids, you can also do, as previously done, aldosterone and renin ratios, okay? Androgen assessment is usually not required. It's not usually required. In females, sometimes people would like to measure it, but not high yield, okay? It's not high yield. Now, management. Glucocorticoids are life-saving, they are critical for life. They have to be replaced always. And for mineralocorticoid deficiency, replace mineralocorticoid. For androgen deficiency, replace androgen. Particularly females benefit for them. For male, this replacement is not required. Now, glucocorticoid replacement is usually, you can use oral hydrocortisone. Here is the recommended dose if you want to remember, oral hydrocortisone. And you should know that this should actually reverse the condition. This should actually make the patient feel better. If it doesn't, then there is some problem. Say, for example, if there's increased weight, maybe patient is taking too much, double dose, for example. Or if there is still pigmentation or lethargy, the patient is not compliant. So you need to, investigate the patient accordingly. But usually 15 to 20 milligrams of daily divided dose of oral hydrocortisone should be enough for the patient to manage. However, this is very important that this is the baseline cortisol requirement. This dose has to be changed in specific circumstances. For example, look here, look, if the patient is undergoing surgery, double the dose of steroids, okay? Hydrocortisone needs to be double. For minor surgery, for major surgery, here is the, and also these patients are recommended to have a bracelet detailing their management that, hey, I'm a patient taking exogenous steroids, because these patients may have emergency acute scenarios. So in public, this should be very, very much labeled that these patients have this problem, okay? And they should actually have, they also train the patient to how to inject themselves with corticosteroids, hydrocortisone. And they usually all the time have an emergency pack with 100 milligram of injections available of hydrocortisone. So we should also do this here in our country as well. There's the standard recommended way to do it. But remember, the 15 to 20 milligrams of daily divided dose of hydrocortisone is the basal requirement. It has to be changed. It has to be changed, okay? Particularly in surgery, you have to double the dose, okay? Or if there is infection or something, you need to manage it according to the scenario, according to the condition. Mineralocorticoid, usually you do, give fludrocortisone, and you keep measuring the blood pressure and electrolytes and renin, okay? Androgen therapy is usually not required, but maybe females may be given, Now, this particular condition called Addisonian crisis is something where the patient has Addison disease already chronically, but then there is a precipitant, okay? There is something wrong with the patient. Now the person presents to you acutely, critically ill, okay? And you see the list of presenting complaints: circulatory shock, severe hypotension, hyponatremia, hyperkalemia, hypoglycemia, muscle cramps, diarrhea, unexplained. Critical patient, seriously ill patient. And now this patient, whenever you get such a patient and you are thinking of Addisonian crisis, always consider that there has been a precipitant. Usually patient comes to you and the attendants tell you that this patient, has a history of Addison disease and he was on this treatment and that treatment. And now suddenly the patient seems like losing life. Now you should always consider that there is a precipitant. Maybe the patient underwent a surgery and the dose was not doubled. Maybe the patient is having infection, things like that, so that you can better manage the patient. Now, management is, because it's a critical patient, so it has to be usually done in severely, controlled environment. You have to correct the blood pressure and pulses, where you get IV saline. You give more hydrocortisone because that has to be, restoring the losses. If it was a surgery or an infection, you use it more. For acute hypoglycemia, you use 10% IV glucose. For hyperkalemia usually responds, to the above treatment. But sometimes, if volume is not corrected appropriately, you may need to give additional potassium, okay? Otherwise, if the volume corrections are done okay, then the patient responds and hyperkalemia is addressed. Sorry, did I say you have to give more potassium? No, the patients present with hyperkalemia, so you have to, administering some stuff which is losing potassium. But usually this is not required. Usually this is not required, okay? I beg my pardon. Usually this is not required. I don't want you to give potassium to a patient who presents to you with Addisonian crisis, okay? I don't want you to add into the trouble. So usually it responds to volume correction, hyperkalemia, okay? Now, one important point for Addisonian patients that you need to remember is you don't have to wait for the laboratory values to come back to you in order to begin your treatment. Start the management, start the treatment, and the labs can follow. Please remember this, okay? You don't have to wait. You don't have to wait. Or the best thing would be, take the blood for cortisol measurement or further ACTH measurements, but take the blood and start the treatment. Treatment is important, and every second, every minute can be critical in these patients, okay? So do not wait for the labs to come back. Just take the blood out, send the labs, and start the management, okay? Labs can come back later, and you can modulate your management plan accordingly. Now, one last thing that we need to discuss here is pheochromocytoma. Now, pheochromocytoma, also called paraganglionoma, if it is happening within the adrenal medulla, this is called pheochromocytoma. But if anywhere else in the sympathetic gain system, then it is called paraganglionoma. What is it? It is basically increased. It is usually benign. Only 10% of the time it is malignant, but it is increased production of catecholamines, okay? So patients usually present with anxiety, panic, tremors, sweating, high heart rate, all these sort of stuff, tachycardia, increased glucose in the body, glycosuria. So these are all the presenting complaints of the patients. And the labs you need to do is, there will obviously be high levels of catecholamines, there will obviously be high levels of urinary metabolites, plasma metabolites of catecholamines. So remember the pathway of catecholamine that we discussed? So the main catecholamines, epinephrine and norepinephrine, and metanephrines and other metabolites can all be high in blood as well as in urine, okay? But here are some important points. 24-hour urinary metabolites are more sensitive. They are more accurate compared to the others, okay? So that's why they are preferred. Now, catecholamines themselves, they have a very, very short half-life, and because they have a very short half-life, their levels are, they usually don't mean much. But the metabolites, they are something to be measured. So 24-hour urinary metabolites, particularly metanephrines and normetanephrines, they give you a very good answer, okay? Also the levels of chromogranin A's, but that's not high diagnostic importance. CTs and MRIs you can do to locate the tumor if it is within the adrenal medulla, where it is. But you can also do the MBBS extra-adrenal sources, MBBS scans, to locate if this is somewhere outside the adrenal. So remember the presentation, remember what you need to do for diagnosing the patients, okay? Now, management of pheochromocytoma, do surgery if it is possible, do surgery. But one important, if surgery is not possible, then it's only the conservative type of management, which is alpha blocker, beta blocker, and kind of controlling the tumor size, which is called the debulking surgery or chemoradiotherapy. So that's sort of conservative management. But if surgery is possible, then you do the surgery, okay? But pre-operatively, this is very important to block the alpha channels, alpha receptors. Very important, using phenoxybenzamine. And then you use beta blockers. So alpha blockers always first and then beta blockers, because if you don't do this, then during the surgery, there may be release of burst of catecholamines leading to, uncontrolled high blood pressure. So you have to control that. And the way to do this is use alpha blockers first, beta blockers, and then perioperatively also you use sodium nitroprusside and phentolamine. And post-operatively, you do annual checkups of these patients, okay? So there are some tidbits that you need to remember for examination points of view, that pheochromocytoma is usually benign. 10% of the times it may be malignant. 10% of the times it may be extra-adrenal. 10% of the times it may be bilateral. So that's called the 10% norms for adrenal glands, okay? You need to remember that. One last thing, and then we are all done. It's called the incidentaloma. It's not uncommon. This is not uncommon, guys. You do a scan and you find incidental tumor-like stuff in a lot of persons, in normal population. These are called incidental findings, incidentaloma, okay? Incidentaloma, right? 4 to 5% of population has this. It's a big number. It's a big number. And don't go blind, that, oh my God, I did a CT scan and there is an incidentaloma in the pituitary, remove the pituitary. No, you're doing wrong. You don't do this, okay? Therefore, in endocrinology, you don't do the scans first. If you do the scans first, you harm the patient. You may remove the wrong organ, okay? So don't go blind with the scans, right? Investigate. And what would you like to investigate, by the way? You would like to investigate if there is, because of that mass that you see on CT scan, incidentally, you would like to see if it is hyperfunctioning, So investigate hyperaldosteronism, investigate hypercortisolism, investigate if this is leading to increased production of catecholamines. Now you already know this. If you have to investigate hypercortisolism, there is an algorithm. For hyperaldosteronism, there is an algorithm. So investigate the pathway, okay? Investigate the pathway and then only make the diagnosis, okay? Right, so with this we come to the end of this adrenal lecture. Next video will be on clinical cases, where we will discuss clinical case scenarios and we will talk about how to diagnose them, what is the next step in the management, what is the next step in the diagnosis, and how you manage the patient well, okay? I hope you enjoyed the lecture. Thank you very much for seeing the video. I once again request you to please subscribe the channel, share the videos, and I'll see you back with more informative videos. Thank you very much.